Okay, and I will actually would you like to, yeah, I'll actually share my screen with everyone. Okay, let me close this. Oh, Andy sent a message or something, I guess. Can everybody see my screen? Can everybody see my screen? Okay. Okay, so let's get started. Let me present. Okay, thank you again for joining us. Again, you're actually attending the second session of the Equipping Muslims with PCOR-based action-oriented research tools. And it would be presented by myself and Dr. Johnson again. She would be introducing some of the big concepts today, alhamdulillah, inshallah. Welcome, everybody. And I would actually like to have Masood say a prayer so that we could get started. Masood, can you share your voice and say the prayer?
Oh, assalamu alaikum. I'm sorry, I actually stepped away for a second.
I sent you the prayer.
I'm sorry?
I sent you the Arabic version of this.
You did, okay. Sorry, I've been busy with stuff. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم اللهم إني أسألك الهدى والتقى والعافى والغنى. O Allah, indeed, I ask of you guidance and piety and chastity, and to be free of depending on anyone except you. Ameen.
Ameen. Amen. Thanks, Masood, for the dua, and let's actually get to all of you. And so today, if you could say your name, who you are, and then, of course, tell us about what is your professional home. What is the name, or what do you call your professional home? And then what drives you to do what you do today? And I will mute myself, so I'll have everybody else, I'll give everybody a chance. Let me mute myself first so everybody else can talk.
Can you clarify what do you mean by professional home?
Fatma, you're muted. So.
There. Okay. So Dr. Becca, I'll have you explain this.
Okay, so I'll give an example. So my name's Rebecca Johnson, and my professional home, it's sort of I think well, it used to be within the Centre for Community Health at Northwestern, but it's now, I'm now a freelancer. So my professional home, the sphere in which I sort of operate, is research engagement science. So that's what that's the ground, or the sort of metaphor for what I like doing. And I would say that's like yes, and I'm driven to do what I do because I think research engagement can reduce health disparities and can improve health equity. And I believe that home, and as somebody who's come from abroad, from England, I have found a home amongst in partnership with community members and also researchers and stakeholders. So I found my home through working with other people and being a researcher. Yeah.
Well, thank you for that clarification. I guess I'll start. So my name is Asim Al-Laythi, and I just graduated last spring from UICU, the Bachelor's of Science in majoring in biology, and I'm currently working as an EMT. I'm in an ambulance, so I guess my professional home would be an ambulance. And I'm currently applying also to medical school. And what drives me to do this is that in the future as a physician, like I want to have that knowledge of like community health and what exactly would help like my patients get better and how I fit into that and get to know my community better and learn the skills and and network with other people. So
Thank you. Go ahead.
My name is Joaria Rasool. My professional home, so I graduated from medical school from Pakistan, even though I grew up in the US. So right now it's kind of more just a volunteer in everything. A lot of community stuff, some medical clinics, etc. And what drives me to what I do and wanting to be involved is mainly like I grew up all over the US in really small communities and big communities. And I always found it really heartbreaking that really simple solutions to health disparities and other situations like that were available, but no one ever took advantage of those programs or resources. And I really want to be a part of the effort to make that more easily accessible for people. And that's really what drives me.
Thank you.
I can go next.
Okay.
So I'm Asna, and my professional home would be, I used to intern at a lot of nonprofit organizations, so I guess that's where my professional home would be, working in nonprofit organizations. And what drives me to do this is that my goal later on in life is to work in either UNICEF or like a huge nonprofit organization like that. So I would love to get the experience that I've learned with like community health, health disparities, so that I can use that to my ability when I work there. Inshallah.
Inshallah.
I can go next. Salam everyone. My name is Nahar. I also just graduated from DePaul, and I've never really held a professional position. So I guess my professional home is still figuring it out. I think that my idea of it is wherever I can be of service to people. And I always try to take a really multidisciplinary approach to internships and volunteering. And I think I'm really adaptable in that way, and I don't want to have just one professional home. So to be decided. And why do I do what I do? I think that ultimately, I really believe in this idea that there should be a mutual understanding and respect for just the dignity of all people. And my degree was in public health, and I think that that's a great way to touch the lives of so many, especially marginalized communities. But I think that at the end of the day, like it's about seeing yourself and other people's struggles and wanting to uplift different communities and learn about them. So I just like want to be a lifelong learner and continue to follow this path wherever it takes me.
Cool. Very nice. Anybody else wants to go?
Yeah, I can go next if that's okay.
Okay, sure.
Assalamu everyone. I'm Wasan. I think my professional home is helping people wherever they are, how small they are, how big they are. Why do I do that? I think my goal is to deliver any piece of good information I know to the people who need that. Whatever they are, how hard was that? I try so hard to give them that piece of information no matter what. That's it.
Okay. Thank you. Jimmy, we haven't heard from you. You're the only one left here with the cohort. Go ahead.
Yeah, so professional home, I would like to say during my undergraduate at University of Illinois, I spent time in the research lab, and research labs have been a place that's been nice and peaceful. That's where I like to be. I like to say I like to help, but also I like for my help to also be behind the scenes, and so yeah, I grew to enjoy the lab work.
Yeah, I just want to share that my professional home used to be community too, the Basque community. In fact, for quite some time, maybe about 4 or 5 years, I was literally in the mosque every other day or so, and ran different kinds of programs. So that was my home to some extent, and I totally understand that how you all would love the community and want to be on there. That's great. Good to hear. Let's move on to today's. We have a loaded session, so I would recommend that people may want to catch a paper and a pencil, just so you want to highlight some of the idea. Even though the sessions are recorded, you can probably circle out or highlight some of the things as you are hearing it. You may want to circle some of the things which you want to revisit. So today, the skills that we would be focusing on would be ability to find and share requested information, ability to respond to questions about a variety of topics, and ability to identify and access, and maybe perhaps a couple more, knowledge about the U.S. Health and Social Services system, and knowledge about social determinants of health. Now, I got to say that some of you who come from public health background, some of these concepts would be repeated. However, the way these concepts are being placed into the context, that's what's more important. How will you use the knowledge that's out there to the best of our community's advantage? So these are some of the keywords that we would be going through today. Healthcare. By the way, you probably have seen the word healthcare written in two different ways: health and space care. I personally, and I believe Dr. Johnson also likes it to write it this way, I like to see the word healthcare together. I don't think there should be a space between health and care. And Affordable Care Act, we would go a little bit more. Literally, we would be scratching the surface, but at least you would get to know a little bit more intricately what the Affordable Care Act is about. And then translational sciences. I just want to take a quick poll. How many people have heard about translational sciences? You can put it in the chat box. Have you heard about the word or the field of translational sciences? A quick yes or a no would be fine. Anyone can give the answer, or however many people would like to answer. Okay. Okay. Yeah, it's a relatively new field compared to some of the things that have been going around, but we would get to it in a bit. Let's actually gauge the size of the U.S. healthcare economy. So we have heard about, it's really big, and it costs $3 trillion or more than that. And then, so in order to have a sense of really what 3 trillion means, is I actually put it into a graph format. So United States total economy is approximately about 18-19 trillion dollars. China lags behind just by a little bit. Japan is 4.4 trillion, Germany is 3.4, UK is 2.8, and France is 2.4. And these are $1 trillion that we're talking about. So if we look at the US healthcare economy, it is actually 3.1 trillion. Now, when I put this slide together, I was unable to find my latest version, by the way. I do have a 2019 version, but the numbers are not that far off. But today's US healthcare economy is about $3.5 trillion. It's actually larger than the United Kingdom's entire economy, just the US healthcare. That's what we are dealing with here. And so if we really think about that, we spend this much amount of money on healthcare, this must be a great healthcare system. So World Health Organization actually compares the different healthcare systems of the first world countries, and they want to see what people are doing right, what they are not, where we can improve. And so half of you are probably familiar with these kind of graphs. However, people who are not familiar with the big public health domains or the World Health Organization's data, big data that come out, for them it's a little bit shift. So I want you to focus on the left side where there is overall ranking, and then the top the countries are laid out. So we are comparing about 11 countries and where they lie in terms of different metrics. So the World Health Organization actually, by the time they analyze the data and get it out, they do it every 5 to 10 years. I believe there is a later version out there that's later than 2010, but it's not much different than this one. Just the numbers are a little bit different, or it's being compiled. I'm not sure whether I saw that if it was a final version or not, but I kept it to 2010 because this graph comes out almost after 10 years. So quality care, we have about 4 different measures within quality, care quality: effective, safe, coordinated, patient-centered. So see, patient-centered is actually a international measure. Coordinated care is an international measure. Cost-related problem, which is access to care, timeliness of care, that's an international measure. Efficiency, equity, and healthy lives. So if you see that the middle and light blue and the middle blue, the light blue or the middle blue or basic blue is actually not the top ranking, and US falls somewhere between the middle and the bottom. The rest of the graph is relatively blue as compared to actually US. So I think we're not best at any of these measures. At the most, we're doing about I want to say 4, which is patient-centered care, which is we're better than some of the other people. But still we have long ways to go. And it comes to access-related problems, that's number 11. Overall ranking is out of the 11 countries, US one of the last ones, actually. So we're spending, this is the world's largest economy. That's how much money we are spending. We're about today in 2010 or 2020, we have about, instead of $8,500, our per capita price tag is $9,000 US. So exactly what's happening? What are we doing that we can't really come up with a better healthcare system? And if you look at UK, it's sitting at $3,400. So, and these are adjusted for dollar amounts. So, where's that $5,000 difference going? You got to be asking yourself that what's happening here. So there's a lot going on, and that's really where we're all trying to hammer out. About 10 years ago, healthcare, U.S. healthcare cost about 3.1 trillion. The healthcare system overall in ranked 37th on WHO's list. 14% of us were actually completely uninsured, and over 45% were underinsured. Elderly had to cover about $25,000 in yearly cost before insurance claims had fully paid their bills. So you may have heard about the donut hole, and that was about $25,000 earlier than prior to 2010, the maximum they were paying. And there was some care coordination there, but mainly there was a disconnect between the healthcare entities. So people ended up paying double for the same thing, or they had multiple tests going on and for the same diagnostics, or for the different diagnostics, they had the same test going on. So duplication of services was quite a problem. Remember, there's a triad of healthcare. Some of you are familiar with this. Or it's called Iron Triangle. So that's what the healthcare system is actually gauged on three things: access, cost, and quality. So if you look at this graph, that's what this graph is about: access, cost, and quality. So going back to and every country is gauged on the triangle, and they try to balance it out, which means that you need to have maximum amount of people, least amount of cost, and top quality. That's what you strive for. However, if you look at the US healthcare, it was actually skewed. So we need to put this back in balance. That's what this is all about. That is why we needed the healthcare reform. So access, 1 out of 7 Americans was uninsured. Cost was not really, cost is still growing, but it has actually tapered out quite a bit. So it's kind of, for the past 2 years, it's hanging around 9,000. So we are now seeing the dent in there. Probably this year's numbers would come out to be better than last year's numbers, because a lot of us actually got monies back from the insurance companies. So we would talk about that as well in the later sessions. That what makes the quality better, and how do we know that we are doing better? And the quality discrepancy. So there are major discrepancies in quality, because the Medicare patients tend to do better than the Medicaid patients. Or overall, we know that Blue Cross's patients do better than some of the other insurances that are out there. So are you guys ready for the big picture? What does this $8,500 per capita or $3.5 trillion economy looks like, right? Look at this. This is our healthcare system, pretty much in its entirety. This picture was put together after the Affordable Care Act was passed back in 2012. I'm still looking for a later version of this picture, but I haven't found one yet. I'm not sure if they actually got it out or not, but I'm going to pause and let's take a look at what's going on this big picture. So you can spot the Secretary of Health and Human Services. You can spot PCORI right there on your top left. You can spot, let me actually, no, I can't, I'm unable to focus it or get it any bigger than this. So I'm going to just leave it for your screens that you may be able to get it larger. Anyways, CMS, you see CDC right there. You see NIH. You have AHRQ, the Health Exchange, which is Marketplace right there. So pretty much every single healthcare entity that's tied to the government, paid by the government, is actually on here, that's somehow related to healthcare. So IRS is there. You can see that. IPAP, physicians. Now notice that Congress in one end, The president is on the other end. The physicians are on the lower left, and the patients are on the lower right. These are the four corners of your healthcare system. Okay, we're going to move further on. So let's focus on exactly how this this big picture, or I'm just going to highlight some of the very major changes that Affordable Care Act or the health reform. Now, health reform was just not Affordable Care Act. It was part of several other acts and several other small bills that were also passed along the same lines. And all of that made up health reform. And we are only going to touch up literally or probably look at the tip of the iceberg. That's about it in this next half hour. So some of the major things that came out was the Center for Medicare and Medicaid Innovation, CMMI. You can see that in the picture that this particular center was established. Patient-Centered Outcomes Research, PCORI, was established. National Center for Advancing Translational Sciences was established. CDC was placed in charge for determining health priorities and vulnerable communities. Medicare Authorization and CHIP Reauthorization Act, MACRA, you may have heard about that. Took place, and AHRQ's policy memorandum that took place for keeping track of the policy. So we're going to dissect out each one a little bit in detail and see how it works on. So in the next few slides, I'm going to lay out the major elements of Health Affordable Care Act, which is PCORI, the CMMI, and the Healthcare Exchange. Those were the major things that that made a huge difference with the cost, quality, and access. So the Patient-Centered Outcomes Research Institute, it was established in 2010 as part of ACA. And the purpose was to fund research that could help patients and those who care for them to make better informed decisions. Now, you've visited PCORI, you've looked into that. One of the facts that I wanted to point out that it's interesting how PCORI was established, how PCORI was funded initially. So the very first thing that with the establishment, the money came from two sources. Part of the money came from the Treasury, but part of the money came from actually the insurance companies. So PCORI is supposed to be an independent entity, free of any biases, and it is for the patient, and it's guided by the patient. That's what this whole center is about. And so the Affordable Care Act mandated that every insurance company or all insurance companies will pay for every insurer $1 per year to PCORI. This was back in 2010. And then the second year, they were to get $2. And after that, PCORI would, or IRS would adjust the fee for PCORI for year after year, and it would be adjusted to inflation. So PCORI's fee for 2020, or is for 2020, is $2.54. It's actually paid by the insurance companies by July 31st. Now, let's say Blue Cross, insures 50 million people. So Blue Cross will pay 2.54 times 50 in fees to PCORI. And this is primarily how the fees are to be paid. So, and then PCORI is to then fund the independent research. So in fact, we are paying into doing this research. So it is in our best interest to actually guide or take interest in our own health and see how we can benefit from some of the advancements that are coming out. So I'm going to move forward. There is some details about that. If any of you would like to read it, go ahead and do some searches and you would be able to find it. If you don't, then you can also come back to me or to understand more about this, how these funding streams go in and how the independent research comes out, because it's extremely important for us to understand that the research is not biased. That's the key. So moving on to the CMMI. Now, what happens is the CMS, it used to be Center for Medicare Services, but after the Affordable Care Act actually made this a Center for Medicare, and it was Center for Managed Care Services actually. But after Affordable Care Act, the name changed to Center for Medicare and Medicaid Services. Now, this particular center is doing a lot after ACA has been implemented. And one of the biggest things that came out of ACA was the formulation of accountable care organizations. So ACOs, you may have heard about that, but all of that happened under the Innovation Center. Why is it called the Innovation Center? Because this is where the people, the hospitals and the big healthcare organizations, the healthcare providers are pooling their resources and delivering care that really makes people better. There are some treatments that does not work, but there are those who work. So the treatments that actually work can actually be incentivized by the government, by the CMS, so they can be implemented across the nation. And that's really where I would definitely highly encourage for all of you to look into the accountable care models. And there's the first generation, second generation, and third generations. We are actually now on the third generation accountable care organizations. In fact, you may have seen Amita Health, you saw Advocate Aurora, you saw all of these hospitals changed their names to some kind of conglomerate, and the reason why is because they became one or the other of part of the accountable care organizations. And each of these organizations actually send data to SCMS and send data to AHRQ so that the measures for their quality measures can be compared from one accountable care organization to the other accountable care organization, understanding that which population is doing better. So a little bit more about the CMMI. If you look at the CMMI levels, these are simply two pictures that I put together. It looks like there's a lot going on, but really not. You have the accountable care organizations are testing treatment models in real life settings as to what works and what does not work. So if you go onto the page for CMS Innovation Center, you look into the different innovation models, you're going to see that some of them actually the stages. So the stage is announced. So there is a primary care transformation. If you look at the lower right corner of your screen, you're going to see that this particular stage has been just announced. It's direct contracting model options. And if you look into that, go into the details of that, then you can look through as to what this is all about. What are the treatments that they are supporting and which ones they are not supporting. Many of these you would see that, for example, a stage no longer active. So Frontier Extended Stay Clinic demonstration, this demonstration is now over, and therefore this is no longer active. And you can look at this stage that's ongoing, which is FQHC's advanced primary care practice demonstration. This is what's going on right now in the FQHC's world. So every type of healthcare provider is actually involved in treating, in testing a treatment model. And this is the reason why patients are involved in different ways, and these healthcare providers are literally testing out different. For example, you may have heard about chronic care model. So CCM and chronic care model is primarily taking a chronic condition and making sure that a nurse or some other ancillary healthcare provider is attached to every patient, where they are helping them educate or overcome their symptom cycle. So this is how the CMMI Center for Medicare Medicaid Innovation, that's what it's working. And once the model is proven successful, then the insurance companies adopt it, hospitals adopt it, CMS adopt it, and becomes part of the best practices. CSC authorized about $10 billion to CMMI back in 2010 for the period of 10 years. So where these 10 billion, so there were $3 million and $10 million worth of grants over the period of every 3 months that came out for the first 3 years. So 2011, 2012, 2013, there was a lot of innovation that went on, and you may have heard about hospitals coming together, become systems being changed. Now, and after 10 years in the ACA implementation, we are actually at a point as community where every single hospital system is a part of one or the other accountable care organization. And this is the year where we saw Blue Cross sending checks to patients back saying that you paid a lot more in your insurance, so here is a $400 check or $500 or $800 check back. Sorry about that. It's there. I had a fix upstairs, so they were late and they've just started some work, but it's going to be over in about 3 or 4 minutes. Sorry about that. So these grants, by the way, they were given to the ACOs, they were given to the bigger healthcare providers, they were given to community-based organizations as well that were a part of treatment model testing. They were also given to big sort of like big groups where they had an insurance company, they had a hospital, they had a bunch of patients, all of them together made a healthcare system. So the grants were given to different groups throughout the communities. And even today, these things actually go on at a smaller level because of the Trump administration. Many of the funding cuts have been taken place, but the first 10 years that the authorization that took place, actually, they were pretty successful ACA implementation years, despite all what you have heard. So another thing, that this was the major thing that happened with the ACA, that it established the healthcare.gov, the marketplace exchange for insurance companies. Now we know that there were 1 in 7 Americans that was uninsured. So marketplace exchange, this was an online sort of a place, healthcare.gov, where insurance companies that were approved by ACA, approved by CMS, that they were Affordable Care Act eligible because there were some services that they were supposed to provide. Not every insurance company.
It was probably embarrassing, though. I really thought it was embarrassing.
So the exchanges actually did not approve every healthcare insurance company. They had to meet a specific criteria to be a part of the healthcare.gov platform, and only the companies that organize it, or insurance companies that provided the essential benefits, were a part of healthcare.gov. So we had $8,500 back then, or $9,000 per capita. That's the price tag, right? So it is that price tag even today. However, in different places of the country, the price of insurance has come down. So, for example, the price of healthcare coverage in the city of Chicago has come down to about between 6,000 or 7,000. And if you go by an off the marketplace lump sum amount, if you want to buy a healthcare plan for 1 year through Ambetter, the price is between $5,000 to $6,000 this year. But a lot of that money is actually coming out from the IRS because of the advanced premium tax credits. If I earn $20,000 and I'm unable to afford my insurance, then ACA mandated IRS to actually pay for my healthcare coverage and adjust it as part of my tax filings. So it becomes a little bit complicated, but this is how the marketplace exchanges worked. So it is indeed a complicated law, and you saw the big picture, but it actually helped millions and hundreds of millions, not hundreds of millions. I'm exaggerating like Trump. It actually, so far, it has helped about 25 through the exchanges, but it has worked. The entire Affordable Care Act has actually helped about 175 million people approximately, because a lot of these are elderly, many of them are Medicaid, many of them are CHIP. So if you aggregate the entire population, there are about 350 million population within the US. Out of them today, about 22 million are still uninsured, and then the rest of them are insured, but they in different brackets. So off of that, about 23, 22 to about 20, about approximately about 20 to 22 million folks, IRS actually pays premium on their behalf to the insurance companies, and that's what gets adjusted in the tax code, and that's how they are able to sustain healthcare coverage through the marketplace exchange. So again, if you have any questions on that, you can put it in the chat box. I would be happy to explain it later, or we can also talk online on the social engine about how these things are working. So these three entities, PCORI, CMMI, and healthcare.gov, this is what they try to do. They are trying to balance the triad of healthcare: cost, quality, access. So I'm going to move on, and let's take a look at the rest half of how the research and development sector worked with the one of the things you've learned about what are ACOs. Name one thing they do. Knowledge check.
I have a question before we enter that. In that slide right before this, where I think they had the triangle and it had PCORI at quality.
Mm-hmm.
So PCORI is just like responsible for research, right? It doesn't oversee the quality.
Yes, exactly. Yeah. So basically what PCORI is doing is it is demanding the quality of care. It is contributing to the quality aspect of healthcare. So access to care is actually is a direct impact. Cost is being dealt with the innovation center as which treatment models are better now, and PCORI is ensuring, because the quality really comes down to the patient quality, the patient care quality for the healthcare. So patient-centeredness is what we are saying that is the forte for the next healthcare cycle, and PCORI is bringing those aspects to light. It's contributing to the quality of care. It's contributing to the healthcare quality in general. Actually, it directly impacts quality.
So like PCORI demands quality, but is there like another entity that oversees the quality?
Oh yes,
evaluates it?
Oh yeah, absolutely. But these, again, let me go back here. So ACA did a lot of things. This is the big picture, right? So ACA did a lot of things. Out of that, we are picking out certain aspects where ACA made the biggest impact. And these three entities that were not there before ACA, they were established as part of ACA to bring cost, quality, and access in balance. And access was dealt by healthcare.gov. Innovation was dealt for the cost. It also was dealt with the quality, but innovation was mainly concerned with the cost, and it still is that which ACO is providing the best quality of care at the lowest price. And PCORI is primarily being patient-centered. It is keeping that quality in check. Okay.
Yeah. Is there a comparison like between before ACA, how much we were spending on healthcare, and then after ACA implementation, how much are we spending now?
So that's the thing. The price tag was actually, this is where we looked at the price tag, or here it was $8,500. Right after ACA, up until last year, up until 2018, I want to say the price tag kept increasing because of the funding that was there to revamp the entire system. So we came up to about $9,000 per capita. Now, in the most recent this year, because of the it's called, there's a term called medical loss ratio, which means how much money are the insurance companies spending on the care, because that medical loss ratio for last year, actually 2019, it has decreased. So which means that the insurance companies are now spending less in actual patient care. So when that price tag drops down, that's when the entire cost will come down. So now we're going to start to see the cost will be lower and lower as we move forward with the implementations that ACA has put in place. It took us about 8 years to literally work with the system to make sure that the implementations for each of the acts have taken place. So, and again, it was many things that actually came about. We're discussing just the highlights of it. So I'm going to move on to the other supporting. So these were some of a few things that we're going to talk about next. And this is about, so this would be Medicare Access and CHIP Reauthorization Act, National Center for Advancing Translational Sciences, and then Center for Disease Control and Prevention. How did that help? And Agency for Healthcare. Now, the National Center for Advancing Translation, that was also put together as part of the ACA. And there was another, the minority department under NIH also was put together, but I did not highlight that piece in here. However, that's a big factor for contributing for the betterment of health disparities. So let's do a quick knowledge check. I'm gonna have the chat box, or look at the chat box. So the question of the day is, or question of the moment is, one thing you have learned about the Affordable Care Act, and what are ACOs? Name one thing they do.
I can start.
Sure, please.
So
Or
one thing I learned is that,
so we can record the answers.
oh, you want me to type it in?
Either way.
Okay.
Go ahead.
So like the Affordable Care Act aim was to basically broaden the healthcare access for citizens. And one thing that I know about ACOs is that like hospitals basically came into systems to evaluate different patient medication and treatments and to see which one is effective. So it can be easily like what's the word I'm looking for? So they can like manage it easier, and like there's a better like overview of what's working and what's not, so it can be further implemented like around the nation.
Okay. Very good. Anybody? Yeah, patients are hidden away in the bottom right corner. Thanks for pointing that out. This is overwhelming, and that's where the patient is. Does ACA cover non-citizens undocumented? Nabil, that was the whole battle with ACA. Oh my God, even to this day, ACA initially wanted to, but there was, again, this is the tug of war between the two parties. In fact, I want to say to some extent, yes, because what happened was the sanctuary cities wanted to have a plan where, for example, if a person goes to a Stroger hospital, the Stroger hospital does not ask them what status do they have. And because of EMTLA law, because if a person is presented with a shortness of breath, or with one of the threatening life life conditions to the ER cannot say no. They have to admit the patient and they have to treat the patient till the patient is out of danger. So because of that law, that predates way before ACA, and they had to keep that somehow. They had to factor that in to ACA. So despite the fact that people did not want the undocumented to be funded, the sanctuary cities had a budget already to support that, and they in fact lumped that up with the Medicaid funding, with the state funding. So at the state level, the states have a lot of authority on those funds that are Medicaid funds, and they are not. So we have county plans, we have hospital plans for the people who can actually get care, but they have to reside within a certain area. They have to go to a particular network only, and they cannot get out otherwise. In fact, the Stroger Hospital is a great place for the undocumented to be served, and one of the best places for care, by the way. Yeah, the care is delayed, but the surgeons, the care providers, the treatments, it's top notch, without any doubt. Okay, I'm going to move on. So as part of the Health Reform Package Consolidated Appropriations Act, National Center for Advancing Translational Sciences, this was a center that actually is now a department of NIH. It was formed under NIH. I believe there are 32 departments or 32 different centers under NIH, and this is one of them. But remember back in the days when I said I was in the lab, I was in the basic sciences research. That's where I was. Between the basic sciences research and the patient, I saw a 30 years difference. And I said, what am I doing in the lab? I need to be out there. I want to see the patients who can be helped. And that was my quest that drove me out and into the hospital market. And through the IT, I came to grassroots level, at community level, in fact. So, but I'm so glad that finally NIH recognized the idea that these gaps needs to be bridged. And the question that I had back in mid-90s, it was answered in 2012 under the Consolidated Appropriations Act by having this translational sciences unit in there. So this translation is the process of turning observations in the lab, clinic, and community into interventions. So we are literally at the forefront as a community health worker. We are at the forefront of taking our observations of the community and turning them into interventions. That's what we are talking about when we talk about community health research. So observations into interventions, from diagnostics and therapeutics to medical procedures and behavioral changes. So this is a huge deal that we are talking about. And in fact, now there are a couple of universities that are giving bachelor's and master's degrees in translational sciences. So not just that we have a center that is helping to bridge this gap, we are now having the education and the curriculum that universities can train people in bridging this gap. So that was a great thing that came out, and I would definitely encourage all of you to look deeper into it. So clinical, so if you will look at it, basic sciences going to clinical research, clinical implementation, public health, and the patient is the core of this. So develop, demonstrate, and disseminate. The cycle goes again. Develop, demonstrate, disseminate. Heard about the quality, the TQM, total quality management? Plan, act, check. Plan, act, check. And that's the TQM. Okay. This was another thing that happened at the National Institute of Health. The National Institute of Minority Health and Health Disparities was formulated. And So I've actually given the links here. You can go in and take a look at it. There's quite a bit of funding that comes out of these. There are many projects that are happening, and I would definitely encourage all of you that actually many community-based organizations and hospitals are involved in this kind of research at the community level. We just need to connect ourselves with them, and there's a lot of work going on out there. So this particular institute or department actually works with minorities. It is focused on minority health and to raise awareness and to disseminate the effectiveness and population level intervention. And basically their job is to help reduce the health disparities or dissipate it. AHRQ. So AHRQ is the Agency for Healthcare Research and Quality. Now, AHRQ was formulated or established long time ago. I don't know exactly when it came out. If you go on the website, I don't remember actually. I read it, but I don't tend to remember that for some reason about AHRQ. But quite some time ago. However, its role has changed as to what it needs to be doing. It is, again, an independent body. We saw it on the map of the big picture. And in 2015, there was a memorandum that came out. In fact, there was in 2013, Congress mandated, and it was a part of also health reform, mandated AHRQ to provide comprehensive overview of the quality of healthcare received by the general U.S. population and disparities. So AHRQ receives data from different places, but the data is not mandated to come to AHRQ. However, with the Affordable Care Act, it is now being mandated. All of this data is going to AHRQ. In fact, you have patient safety databases and patient patient networks from accountable care organizations. Every accountable care organization puts the data into AHRQ's database, and that's how AHRQ gets this report out for all of the different entities. And actually, you can go on the CMS Compare to compare many different healthcare providers with each other as to what should be the norm and where these providers are. So what is their quality of care? And that data is available to public. And that was a memorandum that was passed in 2015. So even you can go in and actually look at this data, comparative data and comparative analysis for healthcare conditions. And so anybody literally can do research just from their own desktop. That's how much wealth of information we have available now because of ACA. So let me go back into the presenter mode. And the CDC. So the role of CDC changed a little bit too. So ACA mandated that CDC is to set up the national health priorities. Earlier, the national health priorities was set up as as part of a support group or part of or other entities that used to get out the health priorities. However, the national health priorities as such, or they used to follow, the World Health Organization actually sends these priorities out for the longest time, and many nations adopt those priorities. However, as part of the ACA, the mandate was that U.S. will have its own national health priorities and a list of vulnerable populations that actually designate that because of these vulnerable populations and because of the amount of dollars that are going into the treating the health disparities, this becomes the national health priority. So social determinants of health really goes in to as an input to facilitate the outcome of the national health priorities. And these are the 5 social. It started out with 6, by the way. This year they have come down to about 5 of them. And this is these 5 are primarily healthcare access and quality, education access and quality, social and community context, economic stability, and neighborhood and built environments. Now, if you look at it, hospital care is not one of the social determinants of health, but in general, Dr. Rebecca would be so much better to explain this material. I'm not doing justice with this material, by the way. But let me actually move over so I can cover up the materials. Eliminating health disparities and inequalities. There are positive. These social determinants of health actually are can be positive or they can be negative. So, for example, you can have better health outcomes or positive social determinants or negative social determinants. And in the next few slides, with Dr. Rebecca's piece, you would actually see the neighborhoods, or last time also she showed the differences between the neighborhoods where better conditions, better social context actually produced better results and better living conditions and a higher life expectancy versus some other environments. So this is what we are talking about here. So the negative social determinants of health comes out to be poor access to education, employment status, unhealthy housing, exposure to general disadvantaged living conditions. And these determinants actually mainly result in stress, which can lead to increased risk of many diseases, including obesity, diabetes. And the researchers estimate that individual behaviors determine the overall health and risk of premature death of an individual by 40%. That's a huge number, 40%. And so hence, individual behaviors, that's where this idea of patient-centeredness also originate, that if we can have people focus on their own behavior, and if we ask them what matters to them, how can we help them to better their healthcare or provide a better health for them, then it would be better outcomes in general. So there are negative and there are positive social determinants of health. Here is certain things. According to a 2009 study by the Joint Center for Political and Economic Studies, eliminating health disparities for minorities would have reduced direct medical care expenditures by $229.4 billion and reduced the indirect cost associated with illnesses and premature deaths by approximately $1 trillion during 2003 and 2006. And these were some of the reports that have come out that really went in as input to formulate the ACA. So now if you look at it, health disparities is a combo pack. You have health on one end, you have social justice, but it's a patient-centeredness where the two of them meet. And if we look at, again, putting the iron triangle back in balance, now this particular picture for the iron triangle is not the healthcare operations as you saw it in previous. This is the healthcare research and development. So you have CDC, you got NIH, and you got AHRQ. Now these agencies, they are not servicing the patient directly or not in direct patient care. However, the quality they maintain, the regulations they come up with, the guidelines that they have implemented, this is what aligns the healthcare systems to bring this triangle back in balance. So you have, and PCORI is sitting right in the middle there because it is literally connecting this triangle back with the delivery of patient services with access to care. So we come out to be research must be done differently. I hope I made a point as to how, why do we have to be doing different research and why is PCORI making such a big difference? I'm going to turn, after this slide, I'm going to turn this over to Dr. Johnson to take things further. But let me explain this a little bit more. This is the last slide. Oh, I've mistitled it, by the way. My apologies for the misnomer. The title is wrong. I will correct it before posting it. But if you look at this, the CE, the research and innovation. If you look at it, PCORI, CMS is there, and translational sciences. Now, this is what's putting the research triangle or the clinical triangle, comparative effectiveness research, this is what's going on. CE is actually stand for comparative effectiveness. So it's comparing the two, the what's right and what's wrong, or what helps and what doesn't help. That's what it should be. What helps and what doesn't help, that's what it's comparing. And this is the take of the comparative effectiveness researches, where these three entities, PCORI, CMS, and NIH, is actually working together to bring that research and innovation to the healthcare market today. Now, the ACOs and the providers, you see that on the lower right-hand corner. These are all the hospital systems and the people who are in direct patient care. On the other hand, you have payers, you have got the insurance companies. Now, the comparative effectiveness research is actually regulating the payers as to what should be paid and what shouldn't be paid. How is that going to affect the patient the patient treatments? The insurance payments are going in to the ACOs and the providers. The CE is also mandating the best practices and the clinical models to the ACOs and the providers. And the ACOs and the providers are actually sending the data to AHRQ, to CMS, it goes into the Medicare data banks. There are performance measures, and all of these measures are funneling back into the comparative effectiveness research. They are looking at these measures. They are saying that, oh, this particular chronic care management protocol for, let's say, for the orthopedic hip replacement patients did not work, but this one did work. So they would go back to the ACOs and they would take those ICD-9 codes or CPT codes out, and they would replace them with the ones that actually works. So this is how you got the diagnostics and the CPT codes. They come out every year. The insurance payers are coming out with their catalogs every year, and all of these databases around this time of the year gets updated into the entire healthcare system. And we all know that, oh, there was a database upgrade. Oh, they actually came out with this new. But this is a yearly cycle. And I want you guys to understand that every year, these treatment options, these best practices are being tested and implemented and weaned out as to what doesn't work. So where is Waldo? How can we help as a community-based organization? What is our place on this map? And with this, I'm going to turn this over to Dr. Rebecca Johnson with introducing the pause for thought. Okay, Dr. Johnson, all yours. I actually should have stopped presenting, and I think it may be better if you present.
Okay. So
I'm going to stop presenting and I'm going to mute myself.
Okay. Okay. All right. So here we go. I think. Can everyone see that? Like, we can see that, but I'm hang on. I don't want to stop presenting. Okay. Oh, but I need the slides. That's what the problem. Actually, it might be easier.
Should I present?
Yes, please. Yes.
Oh, sure, absolutely.
Sorry, I haven't got the slides.
No problem.
Go out and back in again. Yeah.
No problem. Here.
Thank you.
Sure. Just let me know when to move over.
Okay. Yeah. So if you take it on now, so I'll stop presenting. There you go. And then if you can,
oh, okay, sorry.
Yeah,
I forgot about that piece.
Right. Yeah.
Now I need to share again. Okay, there it is. And we go with this slide here, which is pause for
So
thought.
if you click on the link.
Okay.
Yeah, I just wanted it was a pause for thought, so I just wanted you all to sort of just take a moment to breathe.
This is lovely.
Yeah, and if we can make the screen, bigger, then you don't get to see all my stuff. So here you go. That's it.
There. Oh, there. Okay.
Yeah, because I know this is a huge amount of information. I mean, I have to say Fatima has done a phenomenal job in describing an incredibly difficult landscape. But if you want to, in terms of advocacy opportunities and policies, and it is actually a good idea just to keep a track of all of these things. And there is so much going on. That's one of the problems. It's seeing the wood for the trees sometimes, and sort of understanding what can be useful to you. I think that's one of the biggest things. So if we just so Kaiser Permanente sort of sent this round, and I just loved the picture. So just hold your breath for a moment. We'll do it when it comes back to number 1. So here we go. So hold. Oh, yeah. Okay. So, yes, I love that picture. All right. So we'll go on to the next one.
Okay.
Yeah. And I realise that we are a bit pushed for time. So I will, yes, we'll think about that. So, yes, this is where we left off with what I was saying before. So, Fatima's created, she's described this landscape of policies, of reports, of networks, of alliances. So how are you going to first of all, how are you going to sort of make the most of all of those things? And also, how are you going to identify sources of information which are useful to you? And I think it's quite helpful for you because, and that was so great with you sharing your idea of your professional home at the beginning, and how you sort of what drives you and where you'd like to go. Because I think you're all going to at some point need to access sources along this spectrum. So there are mainstream, like government data, academic reports, and then there are also community histories, lived experiences, and stories. So I just wanted to remind ourselves of that. So Fatima's been very much talking today, painting you the picture at the mainstream end of things in terms of the government data, changes to the systems, what things are going on. And we didn't mention the VA, of course, and I'm particularly interested in the Veterans Association, because that is actually the equivalent size of the National Health Service in the UK. So I'm always very interested in that. And I think I'm correct, and a colleague of mine told me that the VA operates quite similarly to the NHS. So that's an interesting, which stands for National Health Service. That's the UK one. But so those are interesting in terms of sort of comparing other sort of health systems. And I think, as Fatima so well did, she linked it to the World Health Organization, to UNESCO, all of these different world bodies which are discussing these issues as well. So if we can have the next one, Fatima, next slide. Yeah, so just to remind you where we ended before, when I was talking, just basically talking you through. So what we'd like to do is we'd like to sort of help you sort of decide which sources are useful to you in your work. So at the moment, there's really interesting big data, which is because the census is happening 2020, and obviously there's obviously all of the COVID-19 science, which is taking place very rapidly, and that's very unusual for science to be working that rapidly. It usually takes up to 17 years for a piece of research to find its way into the system. So there's some very interesting sources going on at the moment, and I don't know whether you'd agree, but I think my experience with the COVID-19 is that health disparities, inequities, systemic issues have become even clearer on the way that the system works to discriminate against patients and discriminate against underserved populations, and those non-citizens, undocumented citizens, has become very stark and very sort of obvious. And I think one of the social determinants of health that researchers have often underlooked is, for example, systematic racism, and so that may have been one thing that you noticed was missing from the sort of the bodies. And I think agencies have actually downplayed that or not considered it enough. And indeed, there's a professor in the back in the UK who's recently he leads the Centre of Health Equity Institute at the University of London, and for him that is a new social determinant of health is people's experience of systematic racism and stress caused by that. So it's evolving, and there are lots of things in the going on at the moment, which I think, but it's sort of what we'd like to do is try and help you sort of have the ability to access the right resources and the tools, and then the methods later down the line for help, sort of make sure that you can do your work to the best of your ability and realize your visions that you so nicely shared at the beginning. So can we have another slide? Okay, so we want everybody at the table having access to appropriate sources, tools, and the methods to engage. So Fatima, I want you to be able to read a research article, a CMS report, recognise which method was employed to collect the evidence, and also understand the lingo. So this is actually a graphic which I like. It's taken from a group called El Futuro, and they wanted they wanted to come up with a toolkit to enable patients Hispanic with Hispanic origin to engage with researchers, and they felt that this was what this is the way to do that. This is the toolkit to do that, and so there are some models and there are some things out there. And as we go through the course, we will be looking for the toolkits and things to help you sort of access resources and also do work with people to do the research that matters. Next slide, please. And as Fatima said, what we're trying to do is we're trying to get research, so it's not passive, it's active, it's research for action. We want you to help you collect information and knowledge, know where the big data about health outcomes and factors comes from, and feel confident engaging with the big data. So we're at this point early in the stage where we're collecting information, but as we go through, we hope that you'll be able to apply the information and the knowledge that you get, and also then begin to reflect and see what's useful to you. So have next slide. So the speaking the same language, which we've got, okay, so well, I'm going to sort of just give you a very basic introduction to the big words that Fatima was using a number of big words: health outcomes, health factors, health disparities, social determinants of health. And so I'm going to go a little bit over that again, but so that we can all get on the same page with those words, and also the idea of big data and why we collect data. Okay, so next slide. So what is big data? So a good example at the moment is the 2020 census, which is going to be incredibly important. And when you go onto the 2020 census website, basically the reason why it's going to be important is it's going to determine congressional representation. So once they've collected the data, they will count the numbers, and then they will possibly redraw the lines. So they're going to the congressional district lines. So they'll determine the congressional representation, and it will also inform hundreds of billions in federal funding every year. So according to the demographic the representation of who is in your area, in your district, will determine how much money that your district receives every year. So for example, in Illinois at the moment, in Congressional District 2, as you can see, I can't remember who is the Congressional District 2, but the key area for them would be this group, 45 to 54-year-olds, because there's 100,000 people there. So there's a large number of people. So the older group there is probably that the congressperson will be more open to thinking about older adult issues. So it's very big data is it's used by government to divvy up the federal funding every year. Okay, so next slide. And for example, the American Community Survey that some of you may have filled in. I don't know whether any of you have done the census, but you also may have been asked to do the community survey. And that again is used to drive decisions about funding. And the data that they use is they look at sex, race, age, income, and there's always a question in a survey of whether or not you're Hispanic, and you say yes or no, and they use that question as well. So those are the categories that are often used to drive the decisions in terms of the federal funds. Okay, next slide. And so what else is it used for? Well, as Fatima said, big data is used for sort of looking at with patients. In the patients, it will be looking at patients' health behaviours, and you've heard a lot about smoking is an example of that, and there's been a lot of public health information about smoking, and lots of data is collected about smoking, particularly in the city of Chicago, the Healthy Chicago 2020, and now Healthy Chicago 2025. So smoking is a big one. There's also the overall health outcomes, which I will explain a little bit more. But that's that's always linked to life expectancy in terms of how long you're going to live, and that's what life expectancy is. And then also the data is used to give health systems scorecards. Scores, and that, I think, as Fatima said, came in with the Affordable Care Act. Before that, there hadn't been sort of as much attention to the quality of the health of health systems, and these are in many cases they're often focused on addressing health disparities. Can we have next slide? So what is the health outcome? So the reason why we talk about health outcomes a lot is that length of life is a health outcome considered an indicator of a state of a nation's health and the effectiveness of its health care. And that's something that's recognised globally as being a sort of a key measure. Okay, so have next slide. And so here's the life expectancy for this is a map showing life expectancy by county for American men, and you can see that the male is all in red, and so those in red who are expected to live have a life expectancy of more than 74 are in red. Sorry, less than 74 are in red, and those who are in yellow, life expectancy between 77 and 80. So there's, as you can see, it's different across the states, and when you drill down by county, it's very different between different areas. I'm trying to see a bit of purple, the 80 pluses. So you can see up in the left-hand corner, there's a little bit of purple up there. And so I think that's some of the, and on the West Coast, there's a bit of purple there, 80 plus. Okay, if you have the next slide. Okay, so, and it changes, and this is why countries keep an eye on it. So US life expectancy for a child born in 1980 was 73, and then in 2014 it was 79. So it's going up, and so government sees that and thinks, oh, we're doing an okay job. Life expectancy is going up, but in that's obviously very different by county, and also very different when you start drilling down further and further, it's different by neighbourhood as well. So this is why government keeps an eye on this. It's sort of it's looking for these discrepancies, for these disparities, and then we would all hope that they would be doing things to address these and address those health disparities. Okay, so if you have the next slide. So health disparities. Yes, so in 1980, counties around America had a much closer life expectancy. So things were everyone was expected to live for the same length of time from their birth. If you knew that if you were a child born at a certain time, it was anticipated, it was projected that you would live to a certain time. And there was, in the 1980, the counties were close in life expectancy. But as you can see, some counties along the coast and in central Colorado and Alaska have seen huge increases in life expectancy over the last few years. So a child born in Santa Clara, that was that purple area we picked out, can expect to live to 83. But the average life expectancy for African-American man born in 2014 in Illinois is 76. And in Arkansas, it's sort of 68.6, we'd say that 69. So you have the next. So there are big differences in terms of life expectancy. So what's happening at county and city level? So at county level, there's a lot of, you might have been asked to do these surveys as well. They do. For example, this is an example, a health impact collaborative of Cook County. So they did a community health assessment, which meant that they were looking at community level data and information, and asking sort of not asking sort of for personal data about people's health. They were asking about the social determinants of health that Fatima mentioned earlier. So things like the environment, the neighborhood, the access to health services. Then at the city has, as I mentioned, it's been trying to measure Chicago's health, and in 2020, and then more recently in 2025, it has had plans, and it's done a good job of reaching out to communities and trying to involve people in sort of working out how to close the life expectancy gaps. And as you can see on here, the point of the Health Chicago 2020 is to close the life expectancy gap. So over the next few years, its vision is for a city where all people and all communities have power, are free from oppression, and are strengthened by equitable access to resources, environments, and opportunities that promote optimal health and well-being. So if you have the next slide. So how is it going to do this? Well, the city is using big data like the life expectancy the charts that I showed you, as well as local data, to identify what the conditions are. So the top 3 health conditions for men and women of all ages in Illinois are coronary heart disease, so top 3 causes of death: coronary heart disease, lung cancer, and stroke. And in the city of Chicago, 3 conditions are heart disease, cancer, and stroke. So there's a similarity between the top 3 causes of death in Illinois and in the city of Chicago. Lung cancer is interesting because I think that may be to do with the city of Chicago, it's cancer, and that includes breast cancers as well. But with lung cancer, it may be associated with particular sort of industries which are sort of more rural or suburban. So if we get the next slide. Okay, so if you want to access the Chicago data, the health data, the place to go is the Chicago Health Atlas, and that will give you reports on a whole set of conditions, not everything, and it's not as good on social determinants of health. But if you want a map of Chicago for health, to see the state of heart disease and its impact on mortality, you'll be able to get that. You'll be able to see, and you'll be able to see it by neighbourhood. So you can search by community area and zip code as well, and you can. Sorry, it's community area. I think they use. Yes, not neighbourhood. It's community area and zip code, and you can sort of get an idea of the issue, the health condition, the priority health conditions, which are impacting the different community areas. So if we have a next slide. Okay, so if life expectancy is our big issue, and what are the contributing factors and the additional factors? Now, government does a very good job of telling us what those are, and sort of and collecting the data on what it thinks they might be, but it doesn't always do a great job of finding out from communities what they think the issues are. So if we go to the next slide. I think yes. So how do we do that? So you've got big data, really big data, which will ask questions, very big questions about your sex, your race, your age, whether or not you're Hispanic, and then there are those core survey data categories. You can also ask similar questions of communities, and this is what we did with Pastos for People. We came up with a very basic survey, community-based survey, which also which collected data, which could talk to the big data, but wasn't the big data. And we got people's opinions on priority conditions and their opinions on core health factors which were impacting the community, as well as asking them to tell us about how they would self-define themselves as a population. So, for example, within the communities that work with on the south side, we have a lot of Haitian colleagues who find it difficult to sort of define themselves using the categories of the big data surveys, and there's good discussion to be had about that, about the categories which are used and how they sort of do or do not actually capture they represent of community populations. You have the next slide. So population refers to all the people of a particular town, area or country or community area. The study of populations and characteristics is called demography, and all big data surveys, as I say, like the American Community Survey, include demographic questions. And demography can be really interesting, particularly when you start tracking it over time and you can see differences and changes. Next slide. So health conditions, just to sort of make sure that we're all on the same page. Health conditions is a word used by health researchers and professionals to describe a disease, an illness, or an injury, any physiological or mental or psychosocial condition or disorders. Now, of course, these often differ from the words we use to describe our own health colloquially. So, a doctor might say, "How's your arthritis?" And a patient should say, "Oh, you mean my creaky joints?" So there's that whole, it is always difficult because people talk about their health in very colloquial ways. And it's, having a communication about health conditions, it can often help if you can sort of translate and talk and help people to feel comfortable about using the words that service providers and doctors need in order to access the resources, but encouraging people to translate that into terms which their grandma or their sons and daughters, the young ones, would also be able to understand. So if you have the next slide. And then there's health factors. So these are the things that impact the health of an individual, community, or population. And it could be educational level, it could be access to healthy water, it could be health behaviors, smoking prevalence, or and it could be access to care. Okay, so that's a factor, that's health factor. All right, so I think okay.
Did you have any of the slides after this?
Can you roll? I'm not sure.
Oh yeah.
Oh yes, I did. Yes. So just some. I know I just don't want to. I don't want to go. I know we're a bit over time, aren't we? So yeah. So I will just to wrap up. I wanted to help you understand the word health disparities, and also begin to translate that into a definition which is useful for you. Because so I encourage you, and also, having talked to you last time, I realised that some of you said you weren't necessarily familiar with reading sort of articles. So I wanted to help you with health research literacy as well. So just a sort of just a little task, it won't take long, is if you can read this scientific abstract, right? The abstract, a scientific abstract, is the window on a piece of work. And the key things are background, methods, and results. So the background will give you the sort of the description, what the scope is. The methods will tell you how the evidence was collected in order to sort of think about the background. And then the results, in this case, this is an article by Dr. Badella. So in this case, he looked at whether or not conventional health disparities research examines health outcomes by religious affiliation, particularly within multi-ethnic minority communities. And he found that it didn't. And he found that there were descriptors for Muslim groups where the terms used were sort of South Asian or Pakistani as proxy terms, sometimes to uncover study of American Muslims. So this is where I wanted to think about demographics, population, how we sort of talk to each other about who we are. And I thought this would also introduce you to a scientific abstract. So just take a few moments to have a look at that at some point. And I'm sure we'll keep coming back to health inequities and health disparities. But thank you. It's nice to be with you all. And so and if you need a little bit more help, guidance in terms of what are the key parts of a scientific paper, this is a great site. This is the NIH site, which is about Know the Science. And these are 9 questions to help you make sense of health research. And I find these websites are very, very helpful. And there are other helpful guidance sort of pointers on that site as well. So thank you.
Okay, any questions, comments, guys? Thank you again. And just a reminder that we're going to be meeting again tomorrow at 5 o'clock. Any questions, comments? Thank you, Dr. Johnson. That was a great, you put things right into perspective with big data. And it really helped to see how cities are using the big data. Oh, there you are. So thank you again for describing how the big data fits into the city and how populations are actually utilizing this data into to the best of their advantage by looking at the priorities and doing the measures. For example, life expectancy, a great measure. There are some other measures like maternal mortality or health conditions. Some of them are elderly when it comes to and geriatrics. I know that's your specialty. There are several measures with respect to elderly people. So how do we how do we get these sub-segments of the population better. So thank you again, everybody, for attending. And again, ask questions if you want to revisit some of these concepts. Revisit it. There, we are actually also recording I'm hoping I'll double check that, because Dr. Johnson provided some great resources in the chat button. So we want to make sure that we have listed those as well. And I think that we would also make these links available on the social engine, where you can simply go in, and that can be your hub to have to actually learn more and make yourself competent to be as a community health researcher. Thank you again. So at this point, we will conclude. And if you have any questions, we will stay a few more minutes to answer any of your questions.
So, Father, I'm going to stop recording at this point.
I was just going to wait for some of the questions. If people have any questions, they can ask. So if we can capture those as well, please. Thank you.
Okay.
Wasan and Javeria, would you like to share some things? Okay, we can stop the recording now. And thank you again, Dr. Rebecca. Thank you again. Thank you, guys.